Hello, everyone. Thank you so much for joining. My name is Sina Hushmand. I'm one of the abdominal imaging radiologists here. Today, I'm going to talk about pancreatic tumors and diseases, specifically with special focus on pancreatic ductal adenocarcinoma being how important it is. PDAC accounts for the majority of the malignancy of the pancreas, and it's currently the third ranking cause of death in the United States, and the incidence is continually going up day by day. It has a very poor prognosis, and for its treatment, there are multidisciplinary teams involved, including radiologists. This graph shows the rate of projected deaths from cancer, and as you can see, the pancreatic cancer, the purple line, the dark purple line, is constantly going up by 2030. It's higher than the liver, colon, breast, and many other types of cancer regarding the number of deaths. So in this presentation, I'm going to review the key anatomic and imaging findings of PDAC and pancreas and highlight expected post-treatment changes and some mimics and pitfalls, which include other diseases of the pancreas, which will be covered in that part. So initial staging of the pancreatic cancer is usually radiologic, but unfortunately, it's usually diagnosed at advanced age. About 20%, only 20% meet the criteria for complete resection, and the majority, when we see them, they are unresectable. And their survival rate is pretty low, and initial staging is one of the important aspects of the determination of the management. By doing that, we will know where is the tumor located, what's its size, extent, and if there's any metastatic disease anywhere else. And as I said before, imaging plays a major role. The goal of the surgeons are complete surgical resection, or R0. R staging is a mostly histologic based staging system, which determines how much residual tumor has remained beyond the specimen. R2 is macroscopic residual tumor, R1 is microscopic residual tumor. In imaging, we have our own staging system, which somehow reflects this. It's been introduced in 2006 and updated sometime later by NCCN. This staging system categorizes the pancreatic tumors into primary resectable, borderline resectable, or unresectable. So CT is the modality of choice for staging of pancreatic PDAC, pancreatic ductal adenocarcinoma, very highly sensitive and specific. It has two phases. Pancreatic phase is a little bit earlier, about 40, 50 seconds. At this time, the pancreatic parenchyma is enhanced maximally, and this helps us delineate the hypoattenuating pancreatic tumor against the parenchyma. As you can see here, the star is this ill-defined area is our pancreatic tumor, and our pancreatic parenchyma is delineated and well enhanced. The other imaging component is portal venous phase, where it's a little bit later, 65 to 70 seconds, and it's mostly used for evaluation of the vascular structures, including portal veins, superior mesenteric veins, also liver mets or lymph nodes in other parts of the body. However, CT has some limitations. A good number, about 10-20% of pancreatic PDAC lesions are isoattenuating to the pancreatic parenchyma, and CT has limitations in detection of small lymph nodes and hepatic metastatic lesions. Perineural invasion is also poorly evaluated by CT. MRI is a good complementary test. It's good, equally sensitive and specific for local extent of disease, and overcomes some of the CT's shortcomings, including being more sensitive for liver metastasis and more sensitive techniques for isoatonating tumors on CT, which we don't see them well. However, MR is not cheap, it's expensive, it takes time, and not available everywhere. Uh, SAR, Society of Abdominal Imaging, and American Pancreatic Association a few years ago came up with this dictation template or guideline for reporting of PDAC at the staging time to help the surgeons and other members of the treatment team better understand and stage the pancreatic cancer. It has been since then, it has been widely accepted by many clinicians and radiologists, and we are currently using them here. And it's very useful. The benefits of this reporting system is that each vessel, each major vessel is separately mentioned, and the degree of involvement is determined vessel by vessel. In addition, there are some additional parts about vascular variants or any other relevant findings which can help the management of PDAC. So for the tumor location and surgery, it's really important to understand where the tumor is, because based on the location, surgical technique changes, and also based on the location and uh, closeness to this different structures, we we determine the staging and resectability of the tumor. Now let's just quickly talk about the different surgical techniques that we have. If you have a pancreatic head tumor or a tumor which is to the right side of the SMV, the surgeons do Whipple procedure, which basically means they take the pancreatic head out with some bowel anastomosis associated with that. If it's at the body or tail, or to the left of the supramesenteric vein, distal pancreatectomy is done. If the pancreatic tumor is in the neck body region with encasement or involvement of the celiac axis, a pulpy procedure can be done where the surgeons removes the celiac artery in an unblocked fashion and the tumor with it. So based on these proximities and the surgical techniques, different vessels, the guideline has determined different degrees of involvement in which determines the degree of resectability. For example, for SMA, if we have no contact, it's considered primary resectable. But if we have less than 100-degree involvement or abutment, abutment means less than 100, is conventionally known as less than 180-degree involvement. That would be considered borderline resectable. And if the tumor is encasing the SMA or involves it more than 180 degrees, or there's extension to first jejunal branch, the tumor is unresectable. Same story for common hepatic artery and portal vein and SMV. The more degree of involvement, or if the involvement makes it surgically difficult, the likeliness of tumor getting into an unresectable category rises. I just don't go into fine details. You can find all of these in the references that I just introduced. This is an example of a primary resectable tumor. The pancreatic tumor is here at the head. Here's the normal pancreatic parenchyma, and here's our SMA. So we have no involvement of SMA. However, SMV is here, and our tumor is kind of here, this hypoatonating, and it touches SMV less than 180 degrees. Another view of the SMV being touched by the tumor, we have the pancreatic ductal dilatation, and probably there is some involvement of the SMV here. So here we have less than 180 degrees of contact and no signs of venous invasion. The vein appears intact. We do not see any tumor in the vein. So this was considered a primary resectable tumor. The SMA was also pretty much intact, and also common hepatic artery is intact here. In the next example, which is a borderline resectable tumor, we have involvement of supramesenteric vein Here we have teardrop deformity, which is a sign of venous involvement. Here, the tumor is basically pulling the wall of the vein into itself, and this is considered a venous invasion of the vein, and therefore borderline resectable. Signs of venous invasion. And the third example is a locally advanced pancreatic tumor where you can see total encasement of celiac artery. Common hepatic artery shows caliber change, which means that proximally the artery is being squeezed by the tumor. This is a locally advanced tumor based on having contact with celiac celiac. Common hepatic artery bifurcation contact is also another sign, but here we don't show that area. As I said before, imaging is CT is limited for detection of lymph nodes, especially the small ones. However, we have to pay attention to detection of any suspicious lymph nodes which are distant to the surgical field, because the surgeons usually take the surrounding lymph nodes, the peripancreatic lymph nodes. They resect them. However, the distant lymph nodes, or the nodes which are close but not too distant, such as infrarenal, retroperitoneal, or any lymph node to the left side of the SMA, are very critical and can determine the management and possibly prevent a futile surgery, because they can make the tumor unresectable. Neoadjuvant therapy is gaining attention and popularity for treatment of pancreatic cancer. However, on imaging, we will have limitations. Dense fibrotic stroma of the PDAC makes it difficult for us to determine residual tumor versus treated tumor and resulting fibrosis. For example, here on the top is a tumor where it undergoes neoadjuvant therapy. In further resection of this tumor was considered R0. However, we still see this mass-like density, but it was all fibrosis. So we are currently not on imaging. We are not really good in determining prognostication after neoadjuvant therapy, and however, studies have shown that any response, any decrease in size, is an indicator of good histologic response in the further steps of treatment. So let's look at this case here. We see dilated pancreatic duct, which kind of, there's like a duct cutoff sign here. We do not see any dilated duct, but we do not see any mass or anything. However, this patient has a pancreatic PDAC. This is an example of a patient with isoattenuating tumor. So there's a tumor hiding here probably. So about 10% of the PDACs are like this, and we have to pay attention to indirect signs such as duct cutoff sign, where the pancreatic duct just suddenly changes caliber. MRI is a helpful modality in these situations. Here we see a restriction of diffusion of a DWI signal at the location of a presumed pancreatic tumor. Here is an example of a rounded, somewhat central necrotic mass in the pancreas. Something that we have to pay attention is that the pancreatic duct seems to be just pushed away, and there is no pancreatic ductal dilatation. So this gives us a clue that this may not be originating from the pancreas, or may not be PDAC, pancreatic PDAC. And as you can see, there is no duct dilatation, and this patient has right nephrectomy. So this was a patient with RCC with metastasis to the pancreas. Usually the RCC metastases are hypervascular and hyperenhancing, but they could also be central and necrotic. So let's talk about some mimics of the pancreatic cancer or PDAC. It could be other tumors or benign entities such as pancreatitis or anatomic variants. Here's an example of young patient, intermittent abdominal pain. This is a little bit of irregular and dilated ducts, but nothing really significant. And here we see no dilated ducts, maybe a little bit of mass-like enlargement. So it makes us suspicious. We want to do an MRI. We do an MRI, we see there is a mass-like area here at the head, but the duct is a little bit irregular, but not too much dilated. If this was a PDAC, we would have expected like a 1 centimeter of duct dilatation or something like that. However, even like further distally, duct appears to be normal in caliber. This was a case of autoimmune pancreatitis. Usually it's difficult to determine, and some of these patients undergo Whipple's and pancreatectomies, but serum markers and clinical trial therapies may be able to help us. I will show you some more examples of autoimmune pancreatitis further on. This is another example of a mass-like lesion at the pancreatic head. Looks like solid and cystic, has areas of calcification. The duct is dilated and irregular, but again, the duct is not terribly dilated. And here we see more calcification. This was a case of chronic pancreatitis, a major mimicker of pancreatic cancer in the population. The pancreatic cancer could coexist with chronic pancreatitis, and actually it increases the risk of it, but overall, it can also hide pancreatic cancer, so we have to be really careful when we are reading images of chronic pancreatitis. So overall, pancreatitis is a challenging diagnosis and regard for differentiation with PDAC. And chronic pancreatitis has a non-dilated duct, and both actually have non-dilated duct. Autoimmune pancreatitis may have mildly dilated duct, and if we see a duct going through a mass, like in an unobstructed fashion, that's also another sign that leads us through benign entities such as chronic or autoimmune pancreatitis. Another example of a mimic. Here we have MRI sequence of a patient with pancreatic mass. Here we see this pancreatic head mass with restriction of diffusion, low-grade enhancement, and no significant dropout in signal and intermediate T2 signal. This turned out to be also no significant upstream ductal dilatation. This was a pancreatic inflammatory pseudotumor. These are benign entities, very rare. They happen anywhere in the body. Unfortunately, the imaging characteristics are very nonspecific, and based on imaging, it's really hard. This patient definitely needs some type of biopsy or tissue sampling. Other tumors can mimic PDAC as well, such as pancreatic neuroendocrine tumor. They're usually hypervascular. There is no ductal dilatation. Or metastasis, which again, no ductal dilatation, RCC being the most common, also being hypervascular. Also, seeing other metastases in the body can lead us to that diagnosis. Lymphoma is usually hypovascular, can mimic PDAC in that fashion. However, they do not cause obstruction of the duct, and again, we may see involvement of other organs. More examples on that coming soon. And another mimic could be solid pseudopapillary epithelial neoplasm, or SPEN, or daughter tumor or daughter cyst. They are typically detected large at the time of diagnosis. They sometimes have calcification, they're well encapsulated, and again, no ductal dilatation. They're usually located at the pancreatic tail. This example shows a pancreas with, so we see dilated duct here, some mass-like enlargements here near the head and neck. So more examples, a few slices below, we see another mass. So this was a patient with multiple PDACs. Usually happens in the setting of multifocal PDAC, setting of main duct IPMN. And next case is an example of pancreatic neuroendocrine tumor. Pancreatic neuroendocrine tumors can be functional or non-functional or mixed. They can be associated with hereditary syndromes or just happen without any association. And as I said earlier, they're usually hypervascular. The large ones can calcify, can be heterogeneous, and show different appearances, but they're usually different than PDAC given their enhancement characteristics. Pancreatic neuroendocrines also have different phases. One of them is cystic neuroendocrine tumor. They can undergo cystic degeneration and only be seen as a unilocular hypoattenuating cyst. However, they usually have an enhancing rim around them. That's something that may help us differentiate them from side branch IPMNs where we see them every day. And if they drain these, they're usually clear fluid and unilocular, as I said earlier. So here's the example of the pancreatic lymphoma. As you can see, it's hypoattenuating ill-defined mass. Can easily mimic PDAC, but there's no ductal dilatation. And we also have renal lymphomatous involvement of the kidney, which shows the extent of lymphoma. Here's an example of SPEN. This is a small one. It's at the tail. This is another one which is a little bit larger. It's hyper-enhancing, mostly solid, maybe a little bit of cystic areas within it. But demographics and other imaging features can help us differentiate them from PDAC or any other tumor. And lastly, tissue sampling. So after surgery, usually based on the studies, 7 to 13 months after the surgery, recurrence happens in PDACs. And our imaging baseline should be done about 2 months after the surgery, so we would not see the postoperative inflammatory changes. And we usually may see some soft tissues at the pancreatectomy bed. We have to keep a close eye on them, but we don't know, they may just be fibrotic tissue or turn into local recurrence. Here are two examples of patients with some soft tissues at the pancreatectomy bed. This patient, after 3 years, has been stable, nothing changed, but this patient has increased degree of ill-defined soft tissue at the pancreatectomy bed, which means that there has been local recurrence. So baseline, post-op baseline is our friend in post-surgical cases. Sites of recurrence are mostly locally at the pancreatectomy bed. They can happen as liver metastases. They can be peritoneal deposits, lymph nodes, or lung mets. Rarely bones are involved. Okay, to summarize, initial staging of PDAC includes resectable, borderline resectable, and locally advanced tumors. Determination of involvement of vessels is critical in initial staging. Structured reporting is a really helpful method to help the treatment team, and treatment response is difficult to assess in post-treatment cases. And we always have to pay attention to the indirect signs which lead us to detect isoattenuating tumors and mimickers of pancreatic cancer. So I have only 3 questions, which I'm just going to review them. I hope you find them helpful. The first one is an 86-year-old with weight loss. What's the diagnosis? I'll just give you 10 seconds to think about it. And okay, so here we see a pancreas. It's enlarged. We see a halo of soft tissue around it. It kind of looks like maybe a patient with like acute pancreatitis, acute interstitial edematous pancreatitis. However, this patient just had weight loss. It was just outpatient visits and nothing else, no pain or nothing. So acute pancreatitis is not even in the choices. It doesn't look normal. It looks a little bit uh, different, especially if I show you the post-treatment. You can see the difference. So this is like 1 month after the treatment. This was a case of a patient with autoimmune pancreatitis. So this was a sausage pancreas, and the patient had elevated IgG4 levels and was treated with steroids after 4 weeks. Here's the follow-up. And definitely not chronic pancreatitis. We don't see duct dilatation or calcifications. And yeah, and no definite mass to think about PDAC. So the other question is about groove pancreatitis. So the images show us kind of a pancreatic head, cystic and solid regions with areas of calcification. So it's kind of like a chronic pancreatitis at the head, at the pancreaticoduodenal groove. So this is our duodenum. This is the pancreas, some dilated ducts, maybe dilated CBD, and some of these are cystic changes in the duodenal wall. This is an imaging characteristics of groove pancreatitis. So groove pancreatitis is not a type of IgG4, and it is a form of a chronic pancreatitis. Sometimes it can appear as acute pancreatitis, maybe superimposed, or just have we may have acute pancreatitis in that location at the near onset or pancreatic duodenal groove. But the typical groove pancreatitis is a chronic pancreatitis with those cystic changes. Groove pancreatitis can be tricky because PDAC in that location can look exactly the same. So we have to have a close eye on it. We have to follow it up and make sure that it doesn't enlarge or get worse. And if you're not sure, we should definitely recommend EUS or FNA. And about the choice D, in groove pancreatitis, usually the lipase is not elevated, and regarding tumors, like tumor markers are also not elevated. Last question is about a 46-year-old man with episodes of gastric outlet obstruction. So if you look at these images in this view, I'm focused on the pancreas, obviously, and we see the pancreatic parenchyma pretty normal here. Looks like there's like a mass-like region, maybe around the duodenum. So what's the best next step? So this patient has is symptomatic surgical. So this is an annular pancreas. So oncology consult is out, ERCP and FNA not needed. Since the patient is symptomatic, there are surgical techniques to divert duodenum out of this circle of pancreas around it. And sometimes annular pancreas can be a mimicker of a pancreatic tumor. I'd like to thank Spencer for helping me with this presentation. And if there's any questions, I'm happy to answer. Thank you so much.